We're going to get started. Thank you for coming. There's delicious food, but we're going to start our program. Thank you for electing to come to this. We're going to be discussing three really disparate things. One is Castleman disease, another one is cold agglutinin disease, and then acute intermittent porphyria. We have some very excellent colleagues who will be joining us momentarily. You'll be able to use your own technology to interact with us. We are not going to pass around microphones, but we're hoping that this will offer you a very inclusive and interactive experience. So I'll introduce myself, and I will have Dr. Mukherjee introduce himself. I'm Ariella Noy. I'm an attending physician at Memorial Sloan Kettering. I specialize in lymphoma and various other diseases, and Castleman is one of those.
I'm Sudipto Mukherjee. I'm the Director of Rare Cancers and Blood Diseases at the Cleveland Clinic, and Castleman disease is one of my clinical and research interests.
And we'll be joined by Catherine Broom from Georgetown, Bruce Wang from University of California, San Francisco, Angelica Irwin from Miami, Florida, and unfortunately, Eileen Weitz will not be able to join us today due to an unforeseen conflict, but Dr. Broom has been very gracious and will be discussing her topic. We'll be talking about the clinical presentation of Castleman, how to select a therapy for multicentric Castleman, and how to collaborate as part of a multidisciplinary team. The floor is yours.
So good morning, everyone. We will start with the Castleman disease, and I will walk through half of the topic, talking about different aspects, and then I'll hand it over to my colleague, Dr. Noy, to go over the treatment aspects of Castleman disease. So this is what you see is a clinical vignette, which is basically how these people present in the clinical practice. This is a gentleman, 47 years old, presented with symptoms of high fevers, intermittent high fevers, night sweats, unintentional weight loss. Very much sounds like a bee-like symptoms that you see in patients with lymphomas. Didn't have any history of any autoimmune conditions or any infections like HIV. He had a workup and all the infectious etiologies were ruled out. He did have axillary palpable lymphadenopathy on presentation. On abdominal palpation, he did have a mild splenomegaly. He did have pleural effusion and ascites. He underwent some laboratory evaluations and was found to be anemic, thrombocytopenic, elevated inflammatory marker, particularly CRP with 10 milligrams, and hypoalbuminemia. So before we go back to that case, a very little bit about Castleman disease. So Castleman disease is basically a heterogeneous collection of non-neoplastic lymphoproliferative disorders, but it can broadly be classified into two different categories. One is the unicentric or localized, meaning the lymph nodes are enlarged and involve one lymph node group or region. And then you have a multicentric where enlarged lymph nodes are found in affecting multiple lymph node regions or groups. And the multicentric can also be subdivided based on the etiology. If it is associated with HHV or human herpes virus 8 infection, it is called HHV8 associated multicentric Castleman disease or MCD. And if no etiology could be found, then it's called idiopathic MCD or IMCD. Lately, another entity has really come into the focus, which is called oligocentric Castleman disease, that falls somewhere in the zone between the unicentric and multicentric. And the presentation of Castleman disease can be, again, very heterogeneous, from mild flu-like symptoms to significant cytokine storm-related manifestations leading to multi-organ failure and in some cases even death. So this is the classification of IMCD that we typically follow for classifying the patients, and it has treatment implications. So for Castleman disease, as we talked in the previous slide, you can have unicentric or multicentric, and the multicentric can be further divided into three categories, one associated with POEMS, which is treated more like multiple myeloma kind of regimen. One is HHV, infection-associated MCD, and the one for which we don't know a cause, hence called idiopathic MCD. IMCD is also further subdivided into 3 different entities because of very different presentation or histopathological features. One is the IMCD IPL, which is called the idiopathic plasmacytic lymphadenopathy. Then you have 2 others. One is IMCD associated with a very aggressive variant called the TAFRO. The TAFRO stands for thrombocytopenia, anasarca, reticulin fibrosis or renal dysfunction, fevers, and organomegaly. And finally, for which you don't have very specific histopathologic identifying feature or TAFRO, they are grouped under IMCD NOS or not otherwise specified. So IMCD is actually an ultra-rare disease. You can call it an orphan disease. In the US, according to the best estimates, because the epidemiological assessment of these conditions are very challenging, is at any year you will have a prevalence of anywhere from 2,200 to 3,200 cases. That comes to about 7 to 10 cases per million population in the US. The median age at the time of diagnosis is 50 years, but it can affect any age category, anywhere from 2 years to up to 80 years. There is no specific sex predilection for involvement. Males and females are equally affected. And prior to the introduction of IL-6 inhibitors, the mortality rate was very high, anywhere from 23 to 45% within 5 years of diagnosis, reaching a high of 60 to 65% within 10 years of diagnosis. But thankfully, since the introduction of IL-6 inhibitors, these numbers have changed drastically, and now we do see in multiple reports of the 5-year survival at 80% or even slightly higher. The biggest challenge with IMCD is there are many, many conditions that mimic IMCD, present like IMCD, but they are not true IMCD. And it is absolutely imperative for the clinicians working with the pathologists to be able to figure this out. And they tend to fall into 3 broad buckets. Is the autoimmune or the rheumatologic conditions as shown here, with the most common ones being the rheumatoid arthritis, lupus, and a whole host of other conditions like adult onset Still's disease, some associated with IgG4 related disease. Then you have infections, particularly HIV or HHV8. And finally, you have to rule out certain malignancies, particularly lymphomas and myelomas, and some esoteric ones like follicular dendritic cell sarcoma. So if you look at this Venn diagram, only a tiny sliver of patients who present with unexplained lymphadenopathy and certain clinical features truly turn out to be IMCD. And the IMCD subtypes can be broadly thought of, clinically at least, falling into 2 of these categories. There is one group of patients who present with lymphadenopathy being the predominant feature. And under this, you tend to suspect they could be either IMCD IPL or IMCD NOS. And some characteristic features of these particular presentations and these entities are they tend to have very high immunoglobulin levels, and they tend to be polyclonal. So it's a polyclonal hypergammaglobulinemia. The inflammatory markers are very high in all cases of IMCD, no matter what, which is shown here as CRP. And interestingly, these cases tend to present sometimes with thrombocytosis. The usual exclusions that we talked about in the previous slide apply here, but there is another subset of patients who present with cytokine storm syndrome. These patients are really very sick and have a very fulminant course, and these patients usually belong to the IMCD TAFRO variant. They are very sick, they have high mortality, they tend to have, unlike the other entities, low immunoglobulin levels and low platelets. They are also characterized by fluid overload issues, either anasarca, pleural or pericardial effusions, and they tend to have an organ involvement, primarily kidney dysfunction. And these presentations tend to get diagnostically challenging and confusing because they tend to mimic HLH or sepsis or an acute lupus exacerbation. So in general, the diagnostic journey of a Castleman disease patient is long and very challenging because of the reasons that we talked about. It's a rare disease, there's a lack of awareness. Appropriate diagnostic evaluation like an excisional lymph node biopsy is typically not performed in most of these patients. It requires multi-specialty involvement to make a diagnosis, particularly a very close interaction between the clinicians and the pathologists. Early diagnosis is absolutely critical because if you delay, they do have complications. And the presentation is very heterogeneous and non-specific. That adds to the confusion. And of course, this is a disease where at some point the patients might have gone through already a whole bunch of different specialists before the diagnosis is made. So this is mostly for the pathologist, but Castleman disease, there are certain histopathological features that are considered consistent with Castleman disease. Important to know that the histopathological features in Castleman disease are variable and they are not specific. So there's a spectrum of changes you see. On the one extreme, you have hypervascular features. On the other extreme, you have plasmacytic features, meaning sheets of non-clonal plasma cells within the germinal centers in the lymph node architecture. But according to the very strict diagnostic criteria that has been laid down, there has to have 5 histopathological features, which is hyperplastic or regressed germinal centers, hypervascularity, follicular dendritic cell prominence, and plasmacytosis. And you have to have a minimum of at least grade 2 or grade 3 severity. You may see some involvement on changes in the bone marrow that too are non-specific but typically seen with TAFRO. You may see a hypercellular marrow with megakaryocytic hyperplasia and sometimes increase in reticulin fibrosis. And probably the key in the diagnostic workup of Castleman disease patient is an excisional biopsy. As much as possible, one should never try to do a fine needle aspiration cytology or core biopsies. In every case, if possible and feasible, an excisional biopsy is absolutely necessary. And as you can see in this slide, the bigger sample on the left where an excisional biopsy was done, you can see the germinal centers. Unlike in the narrow strip where it was a core biopsy done, everything looks normal. So if you did not sample the whole lymph node and just sample one region, it may be you hit a spot where the features were all normal and you would miss it. The symptoms are, the symptomatology of IMCD is very varied, very non-specific as listed here, and which adds to the diagnostic challenges. In 2017, for the first time, an international evidence-based diagnostic criteria for IMCD was established. And this is probably one of the most important defining feature of how we now can accurately diagnose and also help in treating IMCD patients. So this consensus diagnostic criteria requires 3 essential elements based on clinical findings, based on laboratory findings, and based on histopathology findings. So there are 2 major criteria that every patient has to fulfill. One is enlarged lymph nodes, which is defined as at least 1 centimeter in the short axis, involving 2 or more lymph node groups or regions. And second are the histopathological features that are typically consistent with Castleman disease and at least of grade 2 or 3 severity. Then you have minor criteria that includes clinical and lab, and you have to fulfill at least 2 of the 11 minor criteria. And of those 2, one has to be a lab criteria. And these are the ones that are listed here in the slide. And finally, once you have established the major and the minor criteria, the workup is still not complete because you have to exclude all other diagnostic entities that mimic IMCD that falls into the autoimmune bucket, the rheumatologic bucket, infectious disease, and other malignancies, particularly lymphomas and myelomas. I did talk about this in one of the previous slides. These are the 2 features you see, and there will be some patients who will fall in the middle, but predominantly a lymphadenopathy or cytokine storm or somewhere in the middle. And there are some distinguishing features that can help you clinically diagnose them as IMCD, IPL, or NOS, or TAFRO. And this slide just highlights the fact that how these diseases are so difficult to diagnose clinically, because if you look at 3 different conditions here, the adult onset Still's disease, TAFRO variant of IMCD, and HLH, practically in all these patients with different diseases, the inflammatory markers and the cytokine levels are elevated. Ferritin, CRP, soluble interleukin 2 receptor levels, or CD25, and D-dimer. But the magnitude of elevations can be different in different entities. So sometimes having a knowledge of how much is the extent of elevation of these markers in these different entities can help discriminate. And these are the standard labs that one should typically follow in diagnostic workup of these IMCD patients. The protein studies are very important, particularly serum protein electrophoresis with immunofixation, UPEP with immunofixation, and serum-free light chains, because you want to pick up if there's any paraproteinemia like a monoclonal gammopathy. And if you also want to check for quantitative immunoglobulins, particularly IgG4, inflammatory markers as listed here, particularly CRP, rule out the infectious causes. And I won't go over this, but this again kind of re-emphasizes how you can have IMCD mimics with normal CRP levels, with high CRP levels, and even with low CRP levels. So this is a polling question for the audience. Which of the following statements regarding IMCD diagnosis is correct? The first answer choice is requires a histological lymph node biopsy and lymphadenopathy. Number 2, does not require clinical criteria. Number 3, protein electrophoresis must show monoclonality. And number 4, core needle biopsies are preferred.
Yay, good
So
job.
most of the people got it right. The key feature in the diagnosis of IMCD starts with a histopathological diagnosis consistent with Castleman features. So 90% of the people got it right. And now so there are certain life-threatening symptoms of IMCD, and here I'm going to hand over to Dr. Noy, my colleague, to walk us through the rest of the talk.
Thank you very much. You did a great job on your quiz. I like to just add, the people who answered the monoclonality question may have misread it. So what we were trying to point out is that if you have monoclonality, that takes you into POEMS. And since POEMS is treated very aggressively with an autologous stem cell transplant similar to myeloma, you need to make that distinction. So this is a busy slide. We're going to be talking about how to treat specifically idiopathic multicentric Castleman, or IMCD. And I think the real thing here is the dichotomy between non-severe cases and severe cases. So you'll see, just looking at the pattern, I don't think I have a pointer. Do I? I don't. So if you look at the pattern on the right and left, they're basically very similar. But the difference is adding the steroids. So someone coming to you with ascites, a hemoglobin of 6, respiratory failure is going to end up in intensive care. And you won't be able to give them the proper therapy quickly enough to switch everything. So you have to use high-dose steroids. I would say in the non-severe cases, we tend not to give steroids and rely on mostly IL-6 inhibition. You'll notice in both patterns that we're showing the top-level evidence as category 1 in green, and then 2A in yellow, and then blue rituximab. And I'll be showing you some of that data. The key here is that IL-6 levels in IMCD are very high. I like to explain it to my patients as you have a row of dominoes. We don't really know what the first domino is dropping from or falling from, but we know if we put a placeholder in between right after IL-6, we're blocking the cascade of events. One day we're hoping that we'll understand better the etiology, but for right now we're really doing symptom management and trying to get these people back to their regular quality of life. And then you'll see here that the 2B is the rituximab. So siltuximab and toci are both IL-6 inhibition, And then the blue, as you know, is this anti-CD20 antibody. The other key factor is that while I'll show you the data that most patients do have responses, you do end up with some patients who never get better. That's a very challenging situation. We have now a Castleman tumor board that meets once a month through the Castleman Disease Collaborative Network, and this is what we are discussing. Who has Castleman, who should be treated, and when are we going to bail and do something else, and what is that something else? So this was an important study. It's pretty fascinating to me that anyone could do a randomized trial in such a rare disease. It was multinational, randomized, double-blind, placebo-controlled. The reason why it was a randomized phase 2, it wasn't powered to have an outcome analysis that would be necessary for a phase 3. Patients were randomized in a 2-to-1 fashion who had IMCD to receive siltuximab, and at that time there was no standard of care, and so it was randomized to placebo. Patients who had treatment failure could transfer to open label siltuximab, and that's always important when we look at survival differences, because if the transfer to the open label salvages that patient's horrible disease, then they will survive. All right, so you can see here from across the room that in the placebo arm, the primary endpoint analysis was reached in 0% of patients. And then in the siltuximab arm, the partial response rates and CR rates combined were 34%. I'll walk you through this, but one of the reasons why it looks kind of bad, I would say, is that the CR rate is very stringent and would require a complete normalization of all of the lymph nodes. And I'll show you that that's not really the goal for these patients. So this is actually more efficacious than it looks like on this slide. All right. So in two different panels on the right and left, you'll see the independent and investigator assessment. They're essentially the same. So whichever one you want to focus on is fine. The patients receiving the placebo and best supportive care could receive steroids. So there would be some improvement in their lymphadenopathy and some improvement in their symptoms. But for the vast majority of patients, it was really the siltuximab group. And here you can see time to treatment failure quite different in the patients who received the siltuximab. And here is the progression-free survival. And this is what I was alluding to earlier, is that on the top line in red, you see the patients who received siltuximab, and in blue, the base supportive care and placebo group, and then the overall survival not really reaching clinical significance, but there was crossover by design. Now, this was a relatively large study for a rare disease, but can it be replicated by others? And these are real-world efficacy data. The top two probably the most important, since the others are very small series. But combining the two, we have about 70 patients in those two other studies. And you can see here that the CR rates were actually pretty high, and the PR rates a little bit less, but overall the efficacy in the 70 to 80% range, which is more than what was seen in the clinical trial. This is a very, very important slide. I think people ask me this commonly. So do you expect, is this a light switch when you give the anti-IL-6 blockade? Does everything just magically happen? This is a very good paper. I would refer you to it by Dr. Van Ree. And you can see here that the symptomatic response is very brisk. So in most patients, you will know pretty quickly whether someone's getting better or not. And you can see, most importantly, that if you have terrible thrombocytopenia, that will get better in just a few weeks. But the lymph node responses lag. And again, I don't think that that is the most important thing in most patients that have IMCD. You can live with some lymphadenopathy, but these other things like inflammation, being transfusion dependent, those really do affect quality of life. And then there was a long-term extension study. So you can see of the patients who were treated with siltuximab in the original trial, all of them were alive at 6 years of follow-up. And Dr. Mukherjee had very clearly indicated that before this, and I remember this in my fellowship, my first patient died of idiopathic multicentric Castleman. And now it's a completely different story and disease. I won't belabor this, but I will just say that in general, we don't see grade 4 treatment-related adverse events. You might see grade 4 baseline characteristics, but generally the drug is very well tolerated. It is hard sometimes to adjudicate whether your infection, for example, is directly related to the siltuximab or other factors. But overall, this is a very well tolerated treatment. And then this comes up a lot. What about rituximab? So part of the problem is that it doesn't exactly make biologic sense that this disease would respond to rituximab. That there's a lot of confusion because the HHV8, the human herpes virus 8 variant, which is typically associated with HIV, is a different disease, and that does respond and should be treated with rituximab preferably. So if you look here, there is some activity, but generally the complete response rates are much lower, and the overall response rates are much lower. And most importantly, the time to it has a much better progression-free survival if you treat with siltuximab. I know there's a tendency in the community to try rituximab. There's more familiarity with the drug. It's easier to have. People don't have the siltuximab in their formulary, but it doesn't work very well, and it doesn't work for a very long time. So in IMCD, the treatment should be focused on resolution of which of the following? Number 1, anemia. Number 2, fevers and night sweats. Number 3, ascites and pleural effusions. Number 4, all of the above. Excellent. Great. Thank you very much. You passed your quiz for today. I think that's my last slide. Oh, I have another question. I forgot I made two. In IMCD, treatment is stopped when symptoms resolve. I don't think I covered that. That is an unfair question. All right, why don't you guess, and then I'll give you the answer. Excellent. Okay, so we didn't actually go through that. I think one of the really vexing things, I have one patient in my practice who I've been seeing every month for 6 years, and you have to continue the therapy. So I described the dominoes, the stack of dominoes, and unfortunately, because we don't understand what that thing that is causing the cascade to occur, when you do stop the therapy, it's really quixotic. It's just the symptoms come back in 4 weeks, 8 weeks, 3 months, something like that. So for right now, it becomes a lifelong therapy. There are treatments, for example, that are chemotherapy-based, which may stop the whole process. But at this point, the idea of giving lots of people chemotherapy that has a low efficacy rate is not appealing. And hopefully through the Castleman's Disease Network, we'll continue to make progress. I'm going to hand over, we have lots of, I'm going to skip this. I think you all know this by now. We have, quote unquote, the working lunch break. We're going to talk about acute intermittent porphyria, and we're going to welcome Dr. Angelica Irwin and Dr. Bruce Wang.
Thank you.
Yeah.
Okay, So, transitioning over to the acute hepatic porphyrias, we are actually going to start with a question just to kind of set the tone. And so the first question that we have is, when should you consider acute hepatic porphyria as a diagnosis? 1, unexplained abdominal pain. 2, posterior reversible encephalopathy syndrome, or PRES. The third option is muscle weakness and paralysis. 4th, confusion and or hallucinations. And 5th, all of the above. All right, so that's, I think, a pretty good result, and we'll go over most of this in the next half hour. So, starting with a patient who will accompany us through the talk today is a patient who has several of the typical characteristics that we see in patients who present with acute hepatic porphyria. So this is a young woman of reproductive age who presents with severe unexplained abdominal pain after 3 days of progressive prodrominal symptoms. Her pain seems significantly out of proportion to her exam and the lab findings, which are really only notable for tachycardia, hypertension, and mild hyponatremia. And then you get abdominal imaging, and that is unrevealing. However, the patient requires really high amounts of intravenous pain control and antiemetic medications for severe nausea and vomiting. Her pain eventually subsides after about 5 days with extensive supportive care. And when you review her history, it shows that she had a recent infection and that she was on day 7 of antibiotics. And so this is really a pretty typical presentation. Of course, there is variability, but I just want you to keep in mind this severe unexplained abdominal pain, which is one of the main findings and main symptoms that patients tend to present with. So what are the acute hepatic porphyrias? So the porphyrias are a group of 8 inherited disorders that are caused by partial defects or abnormal function of enzymes in the heme biosynthetic pathway. And so here in this picture you can see in the middle the heme biosynthetic pathway with the first precursors, ALA and PBG, and then the porphyrin metabolites. And then in the end, that pathway leads to the production of heme. And heme, in turn, has a negative feedback mechanism to the first enzyme of the heme biosynthetic pathway, which is ALA synthase. And we will be going back to ALA synthase throughout the talk, or later when we talk about treatment. So I want you to keep in mind that this ALA synthase is the first and rate-limiting step in the heme biosynthetic pathway. And so you can see the different enzymes listed here on the left-hand side. And an abnormality of each of these enzymes can lead to a different type of porphyria, which are on the right under disease. And I do want to point out the 4 porphyrias that are characterized by these episodic neurovisceral attacks that we then group under acute hepatic porphyrias. And those are ALAD, AIP, and then further down HCP and VP. And what all of those 4 acute hepatic porphyrias have in common is that they are characterized by a significant elevation of the heme precursors ALA, so delta aminolevulinic acid, as well as porphobilinogen, or PBG. And it has been shown that those 2 precursors or substrates are neurotoxic chemicals. And those are then the chemicals that lead to the symptoms that we observe in acute hepatic porphyria attacks. Among those 4 acute hepatic porphyria subtypes, AIP, or acute intermittent porphyria, is the most common type. And we know that about 80% of patients with AHP, or acute hepatic porphyria, will have AIP. The next two more common, or less common, I guess, types of acute porphyria are variegate porphyria, or VP, and hereditary corporal porphyria, or HCP. The main difference between VP and HCP and AIP is that VP and HCP can also present with photosensitivity, and patients can develop these bullous lesions, blistering mostly on the back of their hands and forearms. And you can see in the picture here, this is a very typical presentation of a patient, a young woman who had in this case, only the photosensitivity reaction. So patients with VP and HCP don't always have both neurovisceral and photosensitivity symptoms. They can have either or, but they can also present with both. In contrast, AIP patients don't have photosensitivity and really only have those neurovisceral attacks. The least common type of acute hepatic porphyria is ALAD deficiency porphyria, which is really extremely rare. There have been about 10 cases reported in literature. Interestingly, they were all males. Those patients tend to present at a much younger age due to the different inheritance, and we'll talk about that. But we will really not focus on ALAD deficiency porphyria because it is so rare. When we talk about the symptoms of acute hepatic porphyria attacks, we almost always think GI, gastrointestinal symptoms. But when we look at the pathophysiology, it is almost more of a neurologic condition because the neurotoxic effect of AL and PBG affects the autonomic nervous system, and that results in the GI symptoms, but also in tachycardia and hypertension. And then it is a significant effect also on the peripheral and the central nervous system. And we see in patients who have these acute attacks that they can develop significant muscle weakness to the point where they sometimes have respiratory failure, need to be intubated. There are reports of cases that were fatal due to the severe muscle weakness in patients who were not diagnosed. Patients develop paresthesias, and then from a CNS perspective, patients often have anxiety and insomnia, and those are two of the prodromes that patients often describe. When they feel an acute attack coming on, they do say they report that they have heightened anxiety, worsened insomnia, and then patients who are in a very severe acute attack frequently present with hallucinations, can have delirium, can have the press. And so really the fact that the neurotoxicity of AL and PBG affect all of these different parts of the nervous system also explains why patients have such widespread multi-organ involvement. And when we look at the signs of the typical presentation of an acute attack, so really the key finding is this severe unexplained abdominal pain, which is usually diffuse. So, and I think here getting a good history is really important because it helps determine whether or not this sound like porphyria or not. Patients typically are not able to localize the pain. They're not able to say it's like in one specific area, but it is really diffuse. And if you have a patient who has or who presents with these recurrent episodes of this unexplained abdominal pain, especially in combination with other findings, for example, pain in other areas, they very frequently have chest pain, back pain, they complain of pain in their legs. Nausea, vomiting, constipation are very frequently present. About 80 to 90% of patients will complain of these symptoms. That should maybe raise the suspicion for porphyria. What I think are red flags where I definitely would want to check for acute porphyria is if patients also have hyponatremia, if they present with muscle weakness, altered mental status, and then a change in urine color, they tend to have a dark brown, reddish, discolored urine. Talking about the inheritance a little bit more, and here we're going back to also talking about ALAD deficiency porphyria. So the most common types, AIP, VP, and HCP, have autosomal dominant inheritance, meaning the mutations are passed from a parent to a child. However, we have to keep in mind that acute hepatic porphyria has decreased penetrance. And that means that not every individual who carries a disease-causing mutation in one of the AHP genes will in fact develop the condition. And so we do know that less than 2% of mutation carriers will eventually develop symptomatic acute porphyria attacks. And that is one of the reasons, or that's the main reason why genetic testing in acute porphyria is not the best diagnostic test. And we'll go into the diagnostic aspect later on. ALED deficiency is a little bit different. Here we have autosomal recessive inheritance, and so here we do not see affected members in consecutive generations, and that's also why ALED deficiency is so much more severe and has a much earlier age of onset. In AIP, VP, and HCP, age of onset is typically after puberty. The acute hepatic porphyrias are rare, but they are more prevalent than it was previously thought. So overall, the prevalence of symptomatic disease, so patients who do have acute porphyria attacks, ranges between about 5 to 50 cases per million people. But the prevalence of mutation carriers, so individuals who carry these disease-causing mutations but might not have symptoms, is much higher. And so it's estimated to be about 1 in 1,500. Just like in many other rare diseases, there is often a significant diagnostic delay, and patients often go 15 years or longer being symptomatic but not being diagnosed, just due to the lack of recognition, but also because there's, the symptoms can be unspecific and there's overlap with so many other conditions. When we're looking at the pathophysiology of an acute attack, so what happens is that there's a genetic mutation in one of the heme synthesis genes, but then there needs to be an environmental or physiologic trigger that increases the demand for heme in the liver. And that then increases the ALS1 expression, so that first enzyme in the heme synthetic pathway. And by activating the heme biosynthetic pathway, due to the increased demand for heme, we then have an abnormal accumulation of the heme precursors, ALA and PBG, which are neurotoxic. So we're having a bottleneck due to the decreased enzyme deficiency further downstream in the pathway. And then ALA and PBG will basically spill out into the circulation and have this neurotoxic effect on nerve endings, as I mentioned before, in the different types of nervous system. So the typical patient who will develop these acute porphyria attacks is female, even though males can be affected as well. But the typical patient is female. The age range is between 16 and 40 years of age, so basically childbearing years. One of the main findings is this poorly localized abdominal pain. Patients often develop chronic constipation, and again, really important when gathering the history from a patient is also the timeline. So there's initial just prodrome that lasts for several days. Then it crescendos into this plateau where patients have this severe abdominal pain, severe symptoms, and then it'll take, unless patients exacerbate and have to be admitted and go into the ICU, but typically then after about 5 days or so, the symptoms start abating. But the duration is always longer, pretty much always longer than 2 days. We typically say somewhere between 3 and 10 days. So if you have a patient who tells you, I have 3 hours of abdominal pain and then it's gone again, or it's a day and then it resolves, it's most likely not acute porphyria. The triggers that we are aware of are certain medications. And here we think mostly about medications that interact with the cytochrome P450 system in the liver. There are databases that we provide our patients and their providers with, where they can enter the medication if they're supposed to start a new medication to make sure that whatever they're taking is not porphyrinogenic, meaning possibly triggering an acute attack. Alcohol and tobacco, physical as well as emotional stress have been shown to trigger acute attacks, as well as sleep deprivation and fasting. However, we do not always find a trigger in all of those patients, so just the absence of a trigger does not mean that it couldn't be acute porphyria.
All right, so now that we've talked about the signs and symptoms, and once we're now thinking about acute porphyria as the potential diagnosis here, how would we make the diagnosis? So, which of the following is the diagnostic test of choice when evaluating someone with an acute porphyria attack? 1, check urine porphyrins. 2, urine delta-aminolevulinic acid and porphobilinogen. 3, porphobilinogen deaminase activity levels. This will be done in red blood cells. 4, plasma porphyrins, and 5, genetic testing. So give one. All right. So As we discussed a little bit earlier about the pathophysiology of acute porphyria attacks, it's the abnormal accumulation of the two precursors of porphyrins, delta aminolevulic acid and porphobilinogens, that are causative of the neurovisceral symptoms. And the way to make the diagnosis of an acute porphyria attack is to look for these two specific chemicals. And the levels are so high in the body during acute attacks that you can check this and detect it in a spot urine sample. There's no need to do blood, and there's no need to do 24-hour urine samples for this. We generally check a urine creatinine to help normalize it across samples, and typically during attacks, the levels are significantly increased, typically more than 10 milligrams per gram creatinine. As reference, the normal ranges, depending on which reference laboratory you check the test, ranges from 0.2 to 2 milligrams per gram creatinine. Right? So during attacks, the elevation is not subtle. I want to highlight that urine porphyrins, on the other hand, are not a good first-line screening test of choice in evaluating patients with acute porphyria attacks. Those are not significantly elevated during attacks. They're not causative to the symptoms. On the other hand, in the acute care setting in hospitalized patients, there's oftentimes mildly elevated porphyrins, especially coproporphyrins, and so it's really a non-specific test. So we not recommend checking that. It is most informative to do the urine testing for ALA and PBG during acute attacks. However, we'll talk in a second about those patients who may have recurrent attacks and frequent recurrent attacks. That's defined as patients who have, on average, more than 4 attacks per year. In those patients, or essentially if you have somebody coming into your clinic who has frequent recurrent symptoms, and you're wondering, hey, is this person having recurrent acute porphyria attacks? In those patients, even in between attacks, when they're feeling at their baseline, the urine ALA and PBG is significantly elevated. So in those patients, even getting a baseline ALA and PBG when they're not in their most symptomatic times can still be very helpful. And if it's normal, it would essentially rule them out for having recurrent acute attacks. As Dr. Irwin mentioned, the acute porphyrias, acute hepatic porphyrias, are genetic diseases of low penetrance. So genetic testing is not recommended as a first-line test because it only answers the question whether somebody is at risk of developing attacks. It doesn't help answer the more important clinical question, which is this person, are the symptoms of this person experiencing due to acute porphyria attacks? To answer that question, we have to do it biochemically by looking for high levels of ALA and PBG in the urine. So traditionally, hematologists as well as hepatologists are the specialists who with the most experience with acute porphyrias, and I think the folks in this audience are going to be the ones who are oftentimes referred for help in making a diagnosis or management for acute porphyria patients. I just want to mention and highlight that there are additional resources available to hematologists. There is a network of porphyria centers here in the U.S. of about close to 20 centers now. So there's a similar network in Europe. And these centers, please reach out to the porphyria consortium centers for additional information for help with both diagnosis and management in these patients. Showing some of the information for the porphyria consortiums. The other place that is an excellent source of information is, especially in this country, there are very good patient advocacy groups for the porphyrias, the United Porphyria Association and the American Porphyria Foundation. And those are good resources both for patients and for providers for finding additional information. All right, so the same patient that we discussed earlier on the initial presentation, now this is a couple of years later, 5 years later, and the same patient is again presenting to the emergency room with a similar presentation of severe unexplained abdominal pain. And upon further history, find out that over the past couple of years, she's had progressively more frequent episodes, each one with a similar presentation as the previous ones. And again, the presentations the findings during the evaluation pretty similar. On the exam is pain out of proportion to the exam. There are very little obvious laboratory findings or imaging findings. The patient was first treated with intravenous fluids for hydration, intravenous opiates for pain control, and antiemetics, and eventually intravenous heme was started, and it was infused through a PICC line, and her symptoms began to resolve after day 3 of treatment. So, in terms of treatment options for acute porphyria attacks, which of the following should be the treatment of choice? Number 1, intravenous dextrose. Number 2, intravenous hemin. 3, givosiran, which is an injected RNA interference medication. And number 4, liver transplantation. So how would we treat a patient in the middle of an acute porphyria attack? All right. So I think this is, we've switch to the question results here. What I wanted to highlight here for treatment of an acute porphyria attack is intravenous heme therapy. So as was mentioned earlier in the diagram of heme biosynthesis, especially in the liver, heme itself feedback inhibits on the first enzyme in the pathway, ALA synthase 1. And in the pathophysiology of acute porphyria attacks, it's the increased expression and then activity of that first enzyme that essentially unmasks the downstream defective mutations that leads to that abnormal accumulation. So one way to stop an attack, and actually the only FDA-approved way of stopping an attack, is to give the patients heme. And heme therapy then reduces that increased ALA synthase activity. It then shuts down heme production in the liver, and then allows the body to get rid of the excess ALA and PBG. All right? So heme synthesis is set down very quickly after giving heme within the first 24 hours, but it generally takes the body about 3 to 4 days sometimes to get rid of the extra ALA and PBG. So we give hemin as daily infusions over 4 to 5 days, depending on the severity of the attack, and usually we don't expect significant symptom improvement until about day 3 of treatment. Okay, so hemo is the first organ drug that was approved by the FDA. It's been available now for nearly 40, 45 years. There are some limitations of heme treatment and some precautions that need to be made. Heme can cause peripheral thrombophlebitis, so we recommend that it be infused through a central vein. When mixing it with albumin, delivering with albumin also decreases that risk. We also recommend doing it that way. Obviously, as this audience knows, heme contains high amounts of iron, so long-term treatment of heme will lead to secondary iron overload, and that needs to be monitored and can be treated with therapeutic phlebotomies if you need to. Now, I mentioned a little bit earlier that some patients with acute porphyria attacks will have recurrent and frequent attacks. And in those patients, one way to potentially manage them is with prophylactic heme given on a regular basis, depending on the frequency of attacks. But in some of those patients, even with prophylactic heme, patients can continue to experience acute attacks and have significantly impaired quality of life. And heme doesn't achieve long-lasting correction of that underlying metabolic defect in the pathophysiology of the disease. So in those patients with frequent recurrent attacks, again, on average, more than 4 or more attacks per year, there is a second treatment that's available, a preventive treatment based on RNAi interference. And this is a liver-specific administration of RNA interference against that first enzyme in the pathway, ALA synthase 1. And again, the goal here is to decrease ALAS1 expression and activity, in this case specifically in the liver, and that will again mask that underlying genetic defect, and this will prevent the abnormal accumulation of ALA and PBG. So how well does this work? It decreases attacks. What I'm showing you on the top here are mean and median annualized attack rates. So this study was done in patients who average more than 10 attacks per year. And with this medication, givosiran RNA interference, it decreased their attacks by 75 to 80%. And that reduction was sustained long-term in the open-label extension and follow-up studies, when we have more than 5 years of data now on those patients. And in the graph below, you can see that it very rapidly lowers both, in this case showing PBG, but ALA as well, that it corrects the biochemical defect. Okay.
And then just briefly going back to our patient who is now in her 50s, she's postmenopausal, but she still has frequent neuropathic pain that is similar to her previous episodes. Even though her exam is normal, her labs are normal, she does have an elevated serum creatinine though, and her urine test shows normal ALA and PBG, so she does not experience any acute attacks anymore. Just a brief question, we probably already had the answer before, but which of the following potential long-term complications are present or can occur in AHP? Polyneuropathy, chronic renal insufficiency, hypertension, hepatocellular carcinoma, or all of the above? Okay, I think most got this correct. Yes, all of the above is correct. So in patients, especially in those who have a history of these frequently recurring acute and maybe untreated attacks and who have had long-standing exposures to ALA and PBG, we see that they often develop these chronic complications, neuropathic symptoms that are similar in nature to what they observed during the acute attacks. However, AL and PBG are typically normal or not consistent with an acute attack.
You're not going to do questions.
It does decrease, acute attack risk does decrease in females after menopause, although we do have some females who still continue to have attacks. But I think most importantly to remember that these chronic symptoms are very difficult to treat. So really early diagnosis and treatment of the acute attacks while they're happening, I think, is extremely important to make sure that, or to at least improve the chances for those patients to not have these long-term complications. In addition to the neuropathic pain that patients experience as a long-term complication, patients also often have chronic kidney insufficiency, chronic renal insufficiency, as well as an increased risk for hepatocellular carcinoma. And both of those are thought to be due to the nephrotoxic as well as hepatotoxic effects of the persistent elevation of AL and PBG. And with respect to management recommendations for the long-term complications, we do monitor kidney function at least annually. And starting at age 50, we do screen for HCC with liver imaging as well as AFP levels every 6 months.
All right, so really I think the take-home messages in terms of the acute hepatic porphyrias are that one, this probably is, although it is a rare genetic disease, this prevalence is probably higher than previously thought. We should think about it in young women of reproductive age with unexplained abdominal pain. We do have very specific tests for making the diagnosis of especially acute porphyria attacks. If you've done on urine for the porphyrin precursors ALA and PBG, and that we do have effective treatments available both for stopping the acute porphyria attack and for prevention of attacks in those patients with frequent recurrent problems, but that there are renal and liver long-term complications, and those should be monitored. All right. Thank you. I'm going to hand it over to Dr. Broom. Skip through this part.
Thank you so much.
Okay.
All right, well, we're going to finish our clinic day with cold agglutinin disease. So we'll start off with a question. The mechanism of chronic hemolysis in cold agglutinin disease is, number 1, antibody-mediated red blood cell clearance in the spleen. Number 2, ADCC mediated by T cells. Number 3, extravascular hemolysis mediated by C3b, mostly in the liver. And number 4, intravascular hemolysis mediated by the membrane attack complex. All right, well, we have a little bit of a splay. Hopefully we can clear some things up as we go through this talk. For the most part, the vast majority of hemolysis that patients with cold agglutinin disease are experiencing is actually extravascular, and it's mediated by C3b deposition on the surface of those red blood cells and opsonization in the liver. So if you're a good hematologist, you know what a cold agglutinin disease smear looks like. And so this is a microscopic view of agglutination of those red blood cells, which is mediated by the IgM. So we have a 65-year-old lady who was referred for evaluation of anemia. She had a history of a COVID infection in December of 2021. In January of 2022, she went to donate blood, but was refused because of a moderate anemia with a hemoglobin of 9. In April, she went to donate blood again and was referred to a hematologist. The workup showed the patient to be modestly anemic. She had an elevated reticulocyte count, an elevated LDH, an elevated bilirubin, and a direct antiglobulin test was obtained. It was negative for IgG, it was positive for C3, and a cold agglutinin titer was 1 to 320. She was referred, her hemoglobin was 11.4, and the patient decided at that point in time that she really didn't want to do anything. Fast forward a few months later, she presented acutely with shortness of breath and chest pain. Her hemoglobin at that time was 5. She was transfused with 1 unit of red blood cells, and she was started on sutimlimab, which is a drug that impacts classical complement pathway activation. Within a couple of weeks, her hemoglobin had significantly improved. About a month later, she started developing acrocyanotic symptoms, mostly in her feet. Her hemoglobin had improved drastically to 11.4. And over time, it was elected to start her on anti-B cell therapy with acalabrutinib. So when we think about cold agglutinin-mediated autoimmune hemolysis, we tend to think about secondary causes, which can include infections like mycoplasma and mononucleosis. These tend to be transient and polyclonal in their IgM expression. Secondary chronic cold agglutinin syndrome is related to a clonal proliferation of IgM, and we tend to see these in low and high-grade lymphomas and autoimmune diseases like lupus and rheumatoid arthritis. We have the very rare paroxysmal cold hemoglobinuria, and that tends to be related to viruses or idiopathic. And then we have primary chronic cold agglutinin disease, which we now know is recognized by the WHO as a singular lymphoproliferative disorder. From a differential diagnosis perspective, once you've identified hemolysis, your next job is to identify whether this is immune-mediated or not. And so we have warm autoimmune hemolytic anemia. It's going to be a very positive direct antiglobulin or Coombs test for IgG. It's going to be weakly positive or negative for C3d, and you're going to see spherocytosis on the smear. If the Coombs is negative, look for autoimmune hemolytic anemia due to IgA, which is rare. And then if you do see spherocytes, you want to certainly think about membrane defects. For cold autoimmune hemolytic anemia, generally, the direct antiglobulin test is going to be weakly positive or negative for IgG, but strongly positive for C3. And if you get a direct antiglobulin test that is positive for IgG, you want to think about paroxysmal cold hemoglobinuria. So cold agglutinin disease is not very common. It only accounts for about 15 to 25% of all autoimmune hemolytic anemia cases. Average age, somewhere in the 6th, 7th, 8th decade of life. Landsteiner actually first described blood agglutination at cold temperatures. In 1918, there was an identification of a pathologic association of cold agglutination with red blood cell breakdown. And then in 1943, was reported by Hortzman and Tatlock, cold agglutinins in the serum of patients with primary atypical pneumonia. So the pathophysiology of this disease, I think, is very interesting. You've got mostly in cold agglutinin disorders, the antibody is going to be IgM in subclass, although rarely it can be IgG or IgA. The IgM at temperatures that are less than core body are going to bind to the big I antigen on red blood cells. That binding, that antigen-antibody complex, interacts with a classical complement pathway and activates that classical pathway. C3b is then deposited on the cells. As those cells circulate back into the core body circulation, the IgM lets go, but the C3b is there and is recognized by hepatic macrophage system, and those cells are subjected to extravascular clearance. Depending on how much complement activation is occurring, there can be some leak over into terminal complement activation. But remember that patients who have cold agglutinin disease have intact CD55 and CD59, which tends to stop most of the terminal complement activation. So the vast majority of hemolysis is going to be extravascular, mediated by C3b, and occurring in the liver. So we just talked about the role of complement. It is this IgM antigen complex that's going to activate the classical pathway, which is going to result in complement deposition on those red blood cells and recognition by the hepatic macrophages. So what are signs and symptoms? We have really two separate pathophysiologies going on here. We have the IgM-mediated and cold-driven symptoms, which include acrocyanosis, livedo reticularis, Raynaud's phenomenon, and in severe cases can actually lead to tissue necrosis or gangrene. And then we have the complement-driven symptoms, which include the hemolysis. We believe that complement is driving a vast majority of the fatigue. The patients are anemic, so they have dyspnea. Of course, that's going to be driven, complement is going to be driving hemoglobinuria as well as jaundice. So when we think about these patients, we tend to think of this as being a very non-serious disorder, and patients don't necessarily need to be treated. But when you look at some data, which was published by Dr. Berenson in 2021, you see that the vast majority of these patients have moderate to severe anemia. Only 24% of them have mild anemia, and then a smaller percentage of them are going to have compensated anemia, but still have evidence of ongoing hemolysis if you look closely at LDHs and bilirubins. I would like to also bring your attention to the fact that the severity of the anemia is not linearly related to the IgM level. We have found that these patients do, in fact, have an increased risk of thrombotic events. A retrospective analysis of the United States Healthcare Database was performed, and 608 patients with cold agglutinin disease were identified. They were matched with almost a 10-to-1 comparison of patients without CAD. And you can see the data here. All thromboembolic events were increased in CAD patients, 30 compared to 18%. Arterial events were doubled in the CAD patients. Venous thromboembolic events were 15% versus 5%. And this risk seemed to be present from the time of diagnosis and continued on through the observation period. I think it's important to remember this about CAD. When patients present with worsening shortness of breath, you may want to consider looking for pulmonary emboli in these patients rather than contributing that symptom to their anemia. What do we need to do to evaluate these patients? Well, of course, we're going to look at their hemoglobin. We're going to look at a cold agglutinin titer. We're going to look at immunoglobulin quantifications. And then in the bone marrow, we want to look at flow cytometry to identify this clonal B cell proliferation. All of this requires specific handling of specimens, and I think that's the most difficult part in dealing with cold agglutinin disease patients. I will tell you, even at my hospital, at Georgetown, tertiary center, we still have some difficulty understanding that we need to keep the samples warm. The best way to do this is to keep them warm from the beginning. You can try to reheat these specimens, but that oftentimes will impact your results. So when thinking about therapy, which of the following factors needs to be considered? Patient preference, symptom complex, comorbidities, hemoglobin level, or 1, 2, and 3. Yeah, so 1, 2, and 3. I tend to put less stock in what their hemoglobin level is and really try to talk to patients about how they're feeling, what type of symptoms are they having, and then certainly the ultimate decision about how you approach this disease must take into consideration the patient's comorbidities and also their personal preferences. So the red cell agglutination, which is responsible for the circulatory symptoms, is really mediated by the IgM. We know, you guys know that this is a pentameric structure, and that is what causes the agglutination, which leads to the circulatory symptoms. When we think about someone who has disabling circulatory symptoms, our thought process about the therapeutic intervention probably needs to go to how can I decrease the titer of that IgM, because the IgM is really what's causing those symptoms, and that would be B-cell directed therapy in cold agglutinin disease. Here's an overview of some of the efficacy profiles from studies of CAD therapies where B-cell directed therapy or plasma exchange were employed. I will say that treating patients with cold agglutinin disease long-term with corticosteroids is definitely not recommended. There have been several studies looking at rituximab and combinations of rituximab with either fludarabine or bendamustine. There's a small amount of data looking at bortezomib and a small amount of data looking at ibrutinib. The thing to remember about the B-cell directed therapies is that it's going to take several weeks to a few months to see the efficacy. Now that's probably okay if circulatory symptoms are your major issue. It's probably not going to be your best choice if hemolysis is really what's driving the patient's presentation. The hemolysis, as we talked about, is really driven by complement. It's driven by activation of the classical complement pathway to generate C3b, which is responsible for the extravascular hemolysis. And then certainly in exacerbations or flares, you're going to get intravascular hemolysis as well. So sutimlimab is FDA-approved therapy. It selectively targets C1s, and C1s is vital in forming the C1 complex, which is C1q, C1r, and C1s, which then goes on to activate the classical pathway. If you block C1s, you get no classical pathway activation. I think things to remember about this molecule is that it leaves the lectin and the alternative pathway intact. There have been several studies looking at the benefits of complement inhibition in cold agglutinin disease. The first was a phase 3 study of sutimlimab in patients with a recent history of transfusion. So these would be what people might call your more severely affected patients. They all had a baseline hemoglobin of less than 10, evidence of active hemolysis, and had received 1 or more blood transfusions within 6 months of enrollment. 2 doses of sutimlimab, it's weight-based. greater than 75 or less than 75 kilos, and it's day 0, day 7, and then every 2 weeks. It's beautiful science. I think when you look at complement activation, as soon as you give this complex, complement activation is essentially halted. Decreases in bilirubin as a measure of shutting off extravascular hemolysis occurs really simultaneously with turning off complement activation. We see C4 levels go up as an indicator of no longer being consumed in classical pathway activation. And we see hemoglobin levels rise relatively rapidly, as you heard in the patient presentation. And even before hemoglobin levels go up, we see improvements in FACIT-Fatigue scores. Long-term safety and long-term follow-up have been really excellent with this drug. The first-year improvements in hemoglobin, bilirubin, and fatigue are maintained throughout long-term observations. Adverse events related to the drug itself are relatively few. No serious events were determined to be related to sutimlimab. The most common treatment-related adverse events were infusion reactions in 2 patients. As you all are aware, inhibiting complement activity can increase your risk for encapsulated organisms. There were no meningococcal infections. And in patients who are congenitally deficient in C1, there is a higher incidence of the development of lupus, but no clinical evidence of lupus or other autoimmune diseases were observed in this patient population. We moved on to a randomized trial, double-blind, placebo-controlled, looking at patients who were mildly affected by their cold agglutinin disease, meaning their hemoglobin was less than or equal to 10, but they had not had any blood transfusions within 6 months of screening and had not had more than 1 transfusion within 12 months. If we looked at their impact on quality of life, you can see a significant improvement in the sutimlimab-treated patients versus the placebo-treated patients. Again, very safe. 14% of the patients had treatment-emergent adverse events, but no significant safety signals were noted in cadenza. And when we look at the crossover in Part A, you can see the sutimlimab-treated patients in the black line, the placebo patients in the red. When they cross over into Part B, they all received active medication, and their improvements in hemoglobin mirrored those who received it in the beginning, and their bilirubin decrements also mirrored those that received it in the beginning, and FACIT-Fatigue scores also significantly improved in the patients who were treated initially with placebo. The long-term data from these trials showed that patients experienced sustained improvements in fatigue and overall quality of life. And interestingly, the mental component of these evaluations was also improved with patients on sutimlimab. I think if you take all of these data in total, this is an elderly population of patients, and I think many of their symptoms are oftentimes relegated to getting older, when in fact, these clinical trials demonstrate that patients' quality of life can be significantly improved. What do we have to think about when we're trying to choose therapy? We've got B-cell-directed therapy, we've got anti-complement therapy. Patients that have a low-grade bone marrow infiltration, but we need a quick response, like when she came in with a hemoglobin of 5, those kinds of factors favor sutimlimab therapy. If patients have already received immunochemotherapy, they have failed, or it's contraindicated due to another comorbidity, complement therapy can also be considered. And while there's not a lot of data, considering using anti-complement therapy as a bridging therapy to B-cell-directed therapy is something to think about. If there's high-grade bone marrow infiltration, or you're treating the patient specifically because of circulatory symptoms, then B-cell directed therapy, an attempt to reduce the IgM levels, would be more beneficial for that particular patient. Here's a list of, again, all of the anti-B-cell therapy trials in cold agglutinin disease and their results, which you will get a copy of these slides and you can review these. Ongoing trials, I think this is really an interesting area of research, and there are ongoing trials looking at BTK inhibitors, anabrutinib, looking at an anti-BAFF monoclonal antibody, which is called povetacicept, and then looking at a PI3 kinase inhibitor, and then also looking at combination of bortezomib, which is a proteasome inhibitor, and rituximab, which is anti-CD20. There is iptacopan study, which is a factor B inhibitor, inhibiting the alternative pathway. Pegcetacoplan, which is a C3 inhibitor, although that phase 3 study was in fact suspended. So thank you all very much for your attention, and I think we're going to turn it over to a panel discussion, which the questions are on that iPad that is sitting there.
Okay, thank you. Okay, Dr. Tamar Tadmor from Ben Sion in Israel says, any experience giving, I'm going to butcher the term, I can't even say it. How do you say the drug?
Sutimlimab?
Sutimlimab, okay, as maintenance and not every other week. It's very intensive to continue, or not biweekly, it's very intensive to continue lifelong. I was thinking the same thing, thinking, wow.
So I don't change the dosing interval for this drug. The thing about complement inhibition that's important to remember is it's either on or off. And so a little bit of complement inhibition is probably not achieving your goal. Certainly patients have reasons why they may need to come late for a dose, et cetera. What we have seen in the clinical trial data and also in sort of real world evidence is that you probably are going to maintain the beneficial effects to around 19 days after the last dose. So there is reasonableness for giving patients some leeway in coming in. I have many patients on the drug. I do give it as home therapy, so that makes it a little bit more convenient for patients to think about long-term commitment to the drug. They all feel so much better that they don't want to be without their medication. So right now, an every 2-week dosing interval is what we have.
Thank you. Dr. Ashok Pai asks, why wasn't the case study patient started on an anti-B-cell therapy when the hemoglobin was 5? Wouldn't that address the underlying issue without continuing the drug indefinitely? I was wondering that too.
Yeah, so when the hemoglobin's 5, your goal obviously is going to be to try to improve that hemoglobin, stop hemolysis as quickly as you can. And if you sort of remember from the data from the Cardinal study and the Cadenza study, hemoglobin starts to rise within about a week of initiating anti-complement therapy. Effects on anti-B-cell therapy are going to take 6 weeks, 8 weeks, 10 weeks, 12 weeks. So you're really not going to get that immediate beneficial effect where hemolysis is concerned.
Could you answer how you combine the two?
So there's no data as of yet on combining the two therapies as initial therapy. I think that in the real world, There have been people who have stabilized patients with anti-complement therapy and then initiated the anti-B cell therapy once the patients are more stable from a hemolysis perspective.
Dr. Friedman asks, why is AIP more common in women of reproductive age? What is the mechanistic link? And I'll add to that, it was very interesting to me because you talked about the penetrance, and you said it seems more penetrant in women or children, females, right? And so there must be something that's going on there in terms of maybe gene expression.
Yeah, so I'll take that question. So we mentioned about triggers. I mean, essentially what we're talking about here is what increases heme production in the liver. And we think one of the primary reasons why women, especially women of reproductive age, are more susceptible to having acute attacks is because of their changing hormone levels. And we think that progesterone, surging levels of progesterone in particular, is a stronger trigger of ALA synthase 1 expression in the liver. And that's the primary reason why it's sort of an 8-to-2 ratio, women to men, of having acute porphyria attacks. And why those attacks in women tend to be much less common, both before the start of menses and after menopause.
Great, thank you. I'm going to butcher this. Dr. Zelget, it's hard to tell because I'm getting the emails, so I apologize. I don't really know the correct name of everybody. When is bone marrow examination needed for a patient with Castleman? That is a very good question. Do you want to tackle that one?
So not every patient with Castleman disease will require a bone marrow biopsy, but certainly in cases where you are high index of clinical suspicion, especially for a TAFRO one, mainly characterized by blood count abnormalities, especially thrombocytopenia. Thrombocytosis is more seen with the IPL and the IMCD NOS versions, but with TAFRO it is low platelet counts, especially if you have, what we typically do is if they have thrombocytopenia associated with other clinical features that are consistent with, clinically consistent with TAFRO, like fluid overload, renal failure, etc., or if somebody has two or more blood count abnormalities, you should have a low threshold to do a bone marrow evaluation.
Sorry for that. That was epic alert. I'm sure you're all familiar with that. Okay, next question from Dr. Brad Lewis. Does the cytokine profile CXCL9, IL-18, IL-6, etc., help distinguish MCD from HLH or other autoinflammatory diseases? I'll take that one. Yes and no. So if we had a chance to go back to the criteria, actually the IL-6 level is not part of the criteria. So those 11 requirements where one of them has to be laboratory and one has to be clinical do not include IL-6. So IL-6 is actually a supportive element, but is not required. It's kind of counterintuitive because we're talking about anti-IL-6 therapy, but that's how it was set up. And I would say from an organization that we seem to be having a sale on HLH. Half our inpatient service right now has HLH. I think it really comes down to, you have to start with the lymph node. And if the lymph node biopsy doesn't have any evidence of Castleman, then you kind of moving on because you have all these other things that you're looking for, especially lymphomas. So I think these protein cytokine profiles are supportive, but they're not part of the requirement to make a diagnosis. Hope that made sense. Dr. Glenn Liu, in your experience regarding AIP, how often is the diagnosis of AIP made by a hematologist versus a gastroenterologist? That's a very good question. Maybe we could give that one to Dr. Irwin.
I think that's a very difficult question to answer. I think in our experience, so I'm a geneticist, so we are typically at the end of the chain, meaning somebody else has to come up with a thought, has to have a suspicion, and send the patients to us. And I think historically, it's more the hematologists who are receiving those types of referrals, but we also have a lot of hepatologists and gastroenterologists, for example, in our Porphyrias consortium. So I think I don't think that I can give a definitive answer here. I also, for example, we've had several diagnoses made on the inpatient side by neurology and by pulmonology. So I think it is really whoever has a high index of suspicion and then sends the appropriate testing is in the end the one making the diagnosis. I don't know, Bruce, if you have...
Yeah, I can add a little bit to it. I think sort of historically the centers have had expertise in this country tends to be either within the divisions of hematology, GI, mostly hepatology, and then occasionally dermatology. We didn't talk too much about the cutaneous porphyrias today, but that's where the expertise tends to be. But I would say that where the context where patients are presenting, especially with acute attacks, probably the ED setting, primary care, and then we talked about the female predominance, so gynecology clinics, and then the initial referral, in my experience, actually a lot of times goes to hematology. For me, it's mostly the California hematologists tend to then refer them back, over to me as an additional referral. But I do think that hematologists are one of the most common subspecialties that get referred for this.
I feel like the highest need for education, though, is in the emergency department, because a lot of the patients have recurrent visits in the ED, and it would be a pretty quick urine test that could be sent. So I think we have a lot of work to do with respect to disseminating the information there.
Thank you. This is for Dr. Broom. Dr. Olapsi Yamade asks, how do we manage the CID-driven symptoms?
I'm sorry?
The cold agglutinin disease-driven symptoms.
How do I manage them?
Yes.
Well, it depends on what symptoms the patient's having. Again, if they're mainly circulatory symptoms, then thinking about, anti-B cell directed therapy. Many of the circulatory symptoms are certainly exacerbated by cold temperatures, and so patients will, wear gloves and hats and scarves and all of those things to try to protect their extremities from the variations in temperature that can lead to agglutination of the red cells. What we do know, though, is that temperature variations really don't seem to affect the hemolysis to the degree that we maybe thought they did in the past. And so if hemolysis, anemia, fatigue that's oftentimes out of proportion to the degree of anemia, these are all complement-driven symptoms and need to be thinking about anti-complement type of therapy.
Thank you. We're out of time. I'm going to invite anybody who had questions to come up so we could be respectful of everybody's other commitments. And thank you very, very much for being part of this panel. And I learned a lot about diseases I'd never seen. All right, thank you.